Hey guys, and welcome to the live stream. Today is going to be a focus on the shoulder. I'm calling this part one because inevitably there'll be a part two. There'll be questions that you guys will have or things that I'll think about adding that will inevitably lead to a part two and probably even a part three. Now, this, of course, is put on by me, my patrons on Patreon help make this possible, but so do all of you, the subscribers, the followers, the commenters, and the likers. So please don't forget to like, subscribe, comment during this video. It really helps, not just with the algorithm, but it also helps me know that there's people out there enjoying this content that want more of it and want me to make more so they can learn more. All right, so what we have here is we have a side view. Let me right over here. We have the side view. We have the front view. I really gotta get a pen. Now, from the side view, you can see what shoulder flexion is. So you can see the nose here, the head here. There'd be like one eye right here. So he's clearly facing forward. And bringing this arm up and this way is shoulder flexion. And if we move the arm going back this way, we have shoulder extension. That's keeping it really simple. We're not going to worry about too much. But this is going to be important when you're doing movements at the gym, when you're doing movements throughout life. Again, assuming you've been cleared by a medical professional to do exercise or activity or whatever, these motions are going to be what you want to pay attention to because quasi-scientifically speaking, these are going to be the motions that when you see people talking in the gym chat rooms or on videos, discussion boards, whatever, even in school, these are going to be the movements that you read or you hear people talking about, and you have to be able to picture them in your mind. So flexion, bringing the arm up and forward, extension, moving it back. Now over here we have abduction. Let's use blue for this, which is bringing the arm up and away. It's like doing the upward motion of making a snow angel, while adduction can think of bringing the arm back down toward your side is adduction. So ab, moving away, adding it to your body, bringing it closer to your trunk. But that's not all that's going on here at the shoulder. Let's take a look here at the next slide. We also have the shoulder blade that we have to look at. And this is not even going to touch on internal and external rotation. I'll talk about that in a little bit here. But at the shoulder blade, of course, rests on the back, right? It's not actually attached to your spine or anything. It is a little bit attached to the actual glenohumeral joint. It makes up the glenohumeral joint. But people find it interesting when you tell them about the shoulder blade because you tell them, hey, it's not actually really attached to your trunk by anything other than muscle versus like your hip, which is very clearly, ball and socket joint with a ligament in there to make sure that it can't go anywhere. So anyway, with the shoulder blade, there's several different movements going on here. We'll start with this one. You have elevation, which of course is just shrugging your shoulders. It's bringing the shoulders up. Then you have depression, which is bringing the shoulders down and back, or in this case, just down. You have downward rotation, which looks like, use blue, downward rotation, which is bringing it down and away in this way. And then, of course, upward rotation is going in the opposite direction. So let's use a bright orange for that. So if that's going downward, this is going upward. So what does that look like? Well, when you shrug and bring your shoulders up and towards your ears, you're getting a little bit of that upward rotation. When you push the shoulders down and back as far as you can, almost like you're getting handcuffed to behind you, that will be a little bit more of that downward rotation. We're going to get into what muscles do what. All of this is really important for, you might be wondering, all of this is really important when it comes to doing things like chin-ups. It's really important for doing functional activities. If you're trying to reach for things overhead, if you're trying to, let's say, climb a rope. So if you're like a CrossFit and you're really interested in climbing rope and you just feel like your left shoulder is lagging and you don't know why, or you're going to bench press and you feel like that left shoulder is stuck and it's not going somewhere. It's also important when it comes to talking about shoulder impingement, which is something everybody hears about, or some sort of tendinopathy or some sort of overuse injury. A lot of it comes down to that the shoulder's not working the way that it should. So moving on before I spend too long talking about that, protraction, which means bringing the shoulder forward. It's the best example I can think of this is when you have a boxer and they throw a punch and that shoulder is all the way forward because they're reaching with that hand, that jab that they're trying to get somebody with. That shoulder is all the way protracted. Versus retraction. Retraction kind of happens if you're doing a row and you're pulling as hard as you can, trying to pull your shoulders all the way back, trying to almost pinch your shoulder blades together. That's more in that retraction area. So, what makes up the shoulder? You have a lot here. You got flexors, which is what we're talking about. It's that motion that brings the arm up and overhead. You have the extensors, which bring it going back. You have the abductors, which is the upward motion of that snow angel, and the adductors, which is the going down on that snow angel. So let's just take a look here at a few of them. Let me change the highlighter if I can get that. Don't know if I have a highlighter. We're going to find out real quick here. So flexors, pec major, the anterior delt, the long head of the biceps. This is one right here that I want you to keep in mind because it's one that I see quite a bit in my own life and when I'm working in the clinic. Very common to see this a little bit flared up and painful, especially up and in the shoulder. The coracobrachialis is another one that's really sneaky that can cause a lot of pain. It's a small triangular muscle right on the front of that shoulder. That one can be sneaky. That one can mimic a lot of other things, and it's not common. Yeah, I've not seen a lot of people that actually have coracobrachialis issues. But when they do have it, it can masquerade as a lot of other things. All of this, of course, is educational to help you talk to your physical therapist or your medical professional, right? And for you to also learn about the human body. Now, let's hop on over here. Extensors, the lats and pec major. You're like, what the heck? How does the pec do flexion and extension? Well, it depends on the position of the shoulder. It depends on the fibers because the actual pec has two different types of fibers. It has the clavicular heads, which run across like this. And then you have the sternal fibers. Let's change colors here to green. That run more like this. And so you can kind of see, having two different pec fiber directions, how they pull differently. Right, so one's going to pull more into extension if you have the shoulder in the right position because it's going to try and pull back, and the other one's going to pull more into flexion. And again, all of that is predicated on the shoulder being in the right position when the muscle activates and pulls. Posterior deltoid, that one just makes sense. That's the back of the delt. It's going to want to pull and shorten, and when it pulls and shortens, it's going to pull the arm back. Teres major is also back there in that general vicinity, as is the lats. And again, here, the long head of another muscle showing up, the long head of the triceps, which kind of makes sense that front to back you have different things going on, right? The long head of the biceps helps flex, the long head of the triceps help extend. Abductors, these are ones that you really hear a lot of people talk about with their rotator cuff having issues, right? The supraspinatus is a huge one. Gets impinged a lot of the time. The middle deltoid, not one that gets impinged all the time. The infraspinatus, one that gets a lot of issues, which we'll get into here in a second. And the trapezius and serratus anterior. Serratus anterior, just real quick, is going to be one of your big protracting muscles, one of your big like puncher's muscles, if you will. We'll get into that here in a second. The trapezius you're going to see here show up quite a bit too, just because there's three parts to it. These are the upper, middle, and lower trap. They all do a little bit, well, they do quite different things, but it's such a large muscle, you're going to see it show up here several times. Adductors, things that pull the arm back to your body, the lats, also pec major, and teres minor. Now moving on to the external rotators. External rotators are things that if you put your arm against your belly, so you have your shoulder at 90 degrees, your elbow at 90 degrees, and you start with the palm of your hand against your stomach, and you, quote, open the door, that's an external rotator. Internal rotators would be the muscles that pull your hand when it's outside your body, when it is furthest away from your body. So like, for example, if you were getting ready to pitch and you're up in this pitching motion and you do this, that's internal rotation. That would be external rotation. So external rotators, infraspinatus, teres minor, the big ones. Internal rotators would be teres major, lats and pec, deltoid, and subscap. So you can see here there's a little bit of an imbalance. Things that externally rotate are heavily outnumbered by the things that internally rotate. It's also one of the reasons why when you get to rotator cuffs, you can kind of imagine most of your trouble, most of your issues, most of your problem children, if you will, are these ones. And sometimes it's this one right here too, subscap. And sometimes teres major. But most of the time, it's the external rotators that are the issue. Scapular depressors, those are, of course, like trapezius, which would be lower trap that would be doing this. The lats and pec major, yes, how lats pull down. Pec major also has the ability to depress the scapula as well. Teres major, again, one of the ones that's off on that fleshy part of your lower flank, or I guess rather maybe your middle flank, but runs down kind of in the same fiber direction as the lat. Infraspinatus and subscapularis also do scapular depression. Elevators, pec minor. So that's interesting, right? Pec major does one, pec minor does the other. Levator scap, which is one that's a lot of pain on a lot of people. The rhomboids and the trapezius. Which one does the elevation? Upper trap. Now, scapular downward rotators is upper and lower trap. So that's two parts of the trap working together. Serratus anterior, which is the big one. That's, again, that punching muscle. Downward rotators, lats, pec major, pec minor, teres major, lower trapezius, rhomboids, protractors, again, serratus anterior, pec major, and pec minor, scapular retractors, rhomboids, middle trap, lats. All of this is just to show you there is a lot going on at the shoulder. Lots of muscles that do different actions that if you're trying to figure out, hey, why is this going on my shoulder? What's going on? I want you just to be able to have this as a resource that you can quickly scan through and say, okay, what is the muscle that does this? So thank you for bearing through this with me up until here. Let's get more into the meat of what I want to talk about. So what? Why is this live stream going on? This live stream is going on because we have a goal. This is in physical therapy, but this is also my personal life. I want strength and I want mobility. I don't just want my shoulder to have full range of motion. I want to be strong in that full range of motion. And so when you look over here at strength, you can have a weakness or you can have tightness, right? So if I have a weak muscle, like my bicep that's trying to do a bicep curl, that's one problem. And I can solve that by trying to strengthen that muscle. But if I have a problem because, say, my tricep is so tight that it's fighting against my bicep, I might have a perceived bicep weakness that's not actually a true weakness. It's just my bicep is having to fight this game of tug of war with the muscle that opposes it. And so in the anatomical world, you have the agonist, that would be my bicep, and the antagonist, which would be my tricep. And that's why I have this yin and yang picture up here, is because muscles typically don't exist in a vacuum. They have the muscle that does one action and one that opposes it. And when one muscle is firing to complete its task, like the bicep, normally the brain is sending a signal to the triceps telling it to relax, to let the bicep go through its full range of motion and to do its intent, to do a bicep curl or to pull a spoon to your mouth. If the tricep is not relaxing, there could be a neurological component, which is what you see in a lot of like stroke victims, but there could also be what's called myofascial tightness, which is that muscle is just really tight. Maybe it has a trigger point, which is also colloquially known as a knot. Maybe it has other things going on. So you have to think when things are going on with your body, hey, is this really this muscle acting out on its own just being an issue? Or is there another issue going on here that could be impeding its movement? Could something be so tight that maybe it's keeping me from being able to do this? Now, the bicep and the tricep are very extreme examples. But when it comes to the scapula and to the shoulder, this is a huge issue. Because if your internal rotators are tight, guess what you're not going to be able to do? externally rotate that well, because if everything is locked into that internal rotation, you're trying to do external rotation, you're not going to have the full range of motion. If the shoulder, the head of the humerus is pulled so far forward that it's almost not out of the socket, but if it's not in an anatomically correct position and more anteriorly located, well then guess what? Your external rotation is going to be limited, because then you have less of that available range of motion to externally rotate. That's the crux of this live stream. We have to keep in mind, sometimes you have weakness, sometimes you have tightness, and it's going to come across as perceived strength deficits. And it's definitely going to come across over here as perceived mobility deficits. But that's the first thing you're going to notice, is that you can't move the way that you want to move. And that gets us into, well, is it capsular? That's the actual joint capsule, the tissues that surround and keep the joint approximated. Or is it antagonist and agonist muscle length? Who knows? But here's the problem. Well, let's just skip to that slide. So here's the problem. Well, does it go that I should do mobility first, and then I should do strength second, and then I get to my goal third? Or is it that I should work on mobility and strength at the same time, and then I get my goal? That's the question. And the more that I'm in the clinic and the more that I'm learning, I used to think up here in the top way, 1 + 2 = 3 versus 1 + 1 = 2. The more that I've learned from my mentors and from the clinic, the more I've learned that you should be going for strength and mobility at the same time. It's no good just to go for mobility and then go for strength, because it's not really time efficient and it's not really life practical. You don't really go through life not loading yourself in the movement, is kind of the thought process. So what I'm sharing with you guys is, if you have a movement deficit, yes, you should be stretching. Yes, you should be trying to get to the bottom. Yes, you should be talking to a medical professional, trying to figure out what's going on. Always, that's what physical therapy is there for, right? But don't think of it in discrete, separate terms of, this is just mobility exercise, this is just a strength exercise. There should be the things that overlap, again, if you've been cleared by a medical professional to do so, to exercise and to get mobility and strength at the same time. A good example of this is, imagine doing snow angels. You're just in the gym, just doing a normal snow angel the whole time. There's very few examples in life, besides maybe jumping jacks, that you're going to be doing that unloaded. A lot of the time, in fact, 99% of the time, I would wager, you're actually having to hold a weight and move it through that plane of motion. So the question comes down to, well, if I am limited in my shoulder range of motion and I can't do on my left arm 100% of that range of motion, but on my right arm I can, what should I do with my left arm, right? That's the question a physical therapist asks when they're looking at a patient and they see that motion deficit. And the question comes down to, well, what do I have to stretch? This is the old thought process. What do I have to stretch and what do I have to strengthen, right? Is it a strength deficit or is it a mobility deficit? If it's a mobility deficit, I'm just going to go in there and stretch it and we're going to see if it gets better. But a lot of the times, especially in the shoulder, it comes down to actually what's driving some of the mobility issues is weakness somewhere else. So if you just try and improve mobility in one plane of motion, like abduction, like doing that snow angel, you're completely missing the fact that, for example, you're being hamstrung by the fact that your periscapular, the muscles around your shoulder blade, are weak and cannot retract, or they can't upwardly and downwardly rotate the way they're supposed to, and that's what's actually causing the deficit. Again, that's not always, but it's a principle that's really important, because when you say, hey, wait a minute, I'm seeing this pattern of mobility, this pattern of movement that the person, that me or a person is trying to accomplish, is hindered. I'm having to go back and think, okay, there's probably a strength deficit somewhere, and that strength deficit is what's turning into a mobility deficit. So if I just try and improve mobility with a wand, I might not actually get out of it what I need to get out of it, right? The wand might not actually do what I want to do. And this is a very normal physical therapy thought from, like, while you're in school, I see a mobility issue, I'm going to tackle it, I'm going to make you stretch, I'm going to make you use some sort of aid, maybe like pulleys or maybe like that wand I was talking about, to force you into being able to do that motion, because I'm going to assume that it's strength or something. Or I'm going to stretch the heck out of one muscle and I'm going to completely miss the fact that these other muscles are weak. So that's why, beginning today, I'm starting to get better at this myself, and I'm encouraging you to think it's not mobility and then strength. I think that's becoming much more outdated. It's actually, I need to do mobility and strength. If I can't do a snow angel motion on my left side as well as I can on the right, I'm going to have to just strengthen muscles. And again, assuming you've been cleared by a medical professional to do so, I'm going to strengthen these things, and I'm going to find a way to strengthen all the muscles that could be impinging me, that could be stopping me from doing this. And by virtue of doing these exercises, I'm going to improve my mobility, because as my brain turns on these muscles and turns off these muscles, by virtue of my body getting back into that pattern of movement, over time, my mobility is going to improve, as is my strength. And the muscles that maybe I didn't even realize I needed to strengthen to get this better range of motion are going to get strengthened by changing how I perceive this. Instead of just trying to stretch that one muscle, let's say trying to really stretch the lats, because that's what's limiting me from being overhead. Instead of just focusing on targeting on stretching those lats, now I'm doing exercises that are going to put the lat into a more stretched position, let's say dead hangs. And then when I go and do my pull-up, because let's say that's what you were limited in, as I do that dead hang, I'm coming down, my tricep is getting a stretch. It's the muscle spindles are sending a signal to the brain saying, hey, we're getting stretched here. The mind says you need to relax a little bit more, so you're getting that stretch at the bottom movement, and then as you contract, you're using all these other muscles around the lats that are helping to accomplish the task as you pull up. And then as you come down, you're eccentrically controlling with the lats, but other muscles are also firing eccentrically. And what you end up doing is strengthening the muscles around the lats. So maybe what you didn't even realize is your scapular depressors on that left side are what's weak, and that's why your shoulder blade was stuck up in a certain way, and that's why you had that mobility issue. But by merit of just doing some of the exercises, you ended up strengthening them, which improved your range of motion. It's something that I think happens all the time in the gym, but it's not something that people really think about in the physical therapy world, because we're so usually focused on just, when we first come out of PT school, let's go after that muscle. That's very long-winded for saying think about mobility and strength at the same time instead of teasing them out into two separate things. So let's again talk about another common issue: shoulder impingement. Shoulder impingement is something that you see all of the time in the physical therapy world. So if a person is diagnosed with shoulder impingement watching this, again, talk to a medical professional. This is educational. This is not medical advice. What does it mean? It basically means the head of your humerus is not optimally situated in the glenohumeral joint, which is leading to structures being impinged. Often it's too far protracted. So if you remember what we were talking about before, from that, let's use the side view. You have the head of the humerus. I'll use blue to be where it should be. And now that it's located a little bit more forward here in the joint, all the structures, let's use a nice purple. All the structures that were here in front of it are now impinged because they're out of anatomical whack, effectively. That's what's happening. So things that are usually the culprits: tight bicep. A lot of the times that tight bicep is hiding in there with this. Tight pec major and tight pec minor, very common. Tight upper trap, absolutely very common. Tight levator scap, very common. Weak lower trap, super common. And weak periscapular muscles, that just means all the muscles around your shoulder blade, super common. So what does this look like? Well, in the yin and yang analogy that I used before, it looks like all the muscles that pull your shoulders up and forward are really strong, and all the ones that pull it down and back are really weak. And a lot of guys, especially the veteran population that like to bench press super heavy, or the weekend warriors, or people that go to the gym all the time, they really heavily train their pecs and they don't really do a lot of rows. For example, what I mean by that is they're trying to get their bench press up to 300, but when you ask them to do a row, a supine or a prone row laying on the bench trying to pull two dumbbells towards you, they can't pull more than 90 pounds together, so 245s. And that leads to a really big front, anterior to posterior, front to back imbalance. So the pecs are super tight and pulling very hard forward, and all those periscapular muscles and those scapular retractors that we were talking about earlier are super weak in comparison to the pecs. It's not even a contest. It's a game of tug of war that you've only ever trained one side for. So that's what I see a lot in the clinic, which is why, is it all of these things? And here, let me circle them. Is it all of these? For a lot of people, it is. For a lot of people, it is. It's all of them. But just stretching, so here we can see that things are tight, right? Here, let me highlight. So here we can see that things are tight. Well, what if I spent 1 week just stretching the biceps, because I thought that was the issue, or just stretching the pec, or just stretching the upper trap, or just stretching the levator scap? Or conversely, what if I just decided, heck, I'm just going to strengthen the lower trap, and I'm just going to strengthen the periscapular muscles? Well, I'm missing out on everything else. And by virtue of doing specific motions, like let's say, in this case, if I had them do a bench press with, let's say, 45-pound dumbbells, or let's say it's me, because I actually had this issue. Let's say it's me. Well, if I take the dumbbells instead of the barbell to do a bench press, and I do a 5-second pause at the bottom of my set every single time I'm doing a bench press, one, I'm going to get tired way faster. Two, I'm going to end up getting a stretch. And that stretch is going to be on my pecs, and it's going to be on my upper trap, and it's going to be on my levator scaps as my scapula comes down and back. And then let's say, okay, I want to strengthen my lower traps by doing prone Ys at the gym, which I do all the time. Well, cool. Guess what I'm also working? I'm also working my periscapular muscles. And when I'm doing those exercises, I'm stretching my pec minor and pec major because they have to relax in order to let me retract my scapula. My tight upper trap is having to relax to let my lower trap work. And my tight levator scap is also having to relax to let my lower trap work and my other scapular depressors. That's what I mean when I say it's mobility and strength. I'm doing an exercise to strengthen that's also going to provide me mobility improvements. I'm not going to just stretch my pec. I'm not going to just do a doorway stretch. I'm not going to just do a wand stretch. I'm going to go and I'm going to lift weights, but I'm going to lift weights in a way that consciously puts my body in a position where it needs to stretch those muscles. And those muscles are going to get the turn off signal, if you will, from the brain saying, hey, why are you so tight? You're actually keeping my lower trap from being able to fire the way that it needs to. That's what the crux of this is I'm talking about. So again, so what? Do we stretch these things? Do we strengthen these things? Kind of. It comes down to how. And that's the analogy that I was just giving you. It's about how you stretch. It's about how you strengthen. It's about how you go after these things. And usually people break it up into I'm going to stretch first and then strengthen. There's really nothing wrong with that. It's just not the biggest bang for your buck, and it's not the biggest return for your time, and it's not the most functional. And to be honest, unless you stretch every day for the rest of your life, it's something you're likely going to lose, versus if you go to the gym a lot and you can be taught a pattern of movement or a series of exercises to do that already put your body through that range of motion, you're much more likely to do that than just sit at home and use a wand or a broom to do mobility. And so here we can see some earlier videos that I had where all I did was focus on mobility. And again, there's nothing wrong with just mobility, but the problem is when in your life as a industrialized citizen of the Western world, for example, do you just do mobility unless you're going to yoga or unless you're going to physical therapy? And the answer is probably not that often. Just like me, you drive sometimes 5 hours across country to spend the holidays with your family, and you find out that you're really, really tight in the shoulders, and you're really, really tight in the lower back, and your hips are tight now, and your hamstrings are tight now. And yes, you can go and stretch. Stretching is great. But you're not going to be as diligent, and you're probably not going to stick with stretching the way that you should. You're probably not going to do that 3 times a week prescribed by your physical therapist stretches. You're probably going to maybe do it once, and you'll be like, I felt pretty good, actually. That's what all this was, right? There's nothing wrong with any of this. If you have the time for it, awesome. If you have a free weekend, you're like, I really just need to put myself in what we call the nothing box and think about nothing and just go through a movement flow, awesome. But the reality is most people actually go to the gym and do exercises and lift weights, and that's where this comes in, where you can have mobility with resistance. So like the open books here. Why would I do just normal open books? when I could do resisted open books and I could strengthen the muscles that do thoracic and lumbar rotation and also do scapular retraction and also help me with a whole bunch of other things. Why wouldn't I do that and load those muscles and get the strength component while getting the movement component, right? And the answer would be maybe if it's painful, which is you should be talking to a medical professional, or you have some weird issues like numbness and tingling, and you should be talking to a medical professional. Over here with the face pulls, great video on that by me. You can go check it out. Face pulls are awesome. They're a movement component, and they also help with my neck pain when I used to get neck pain and my shoulder pain when I had shoulder impingement. Why? Because they strengthen the periscapular muscles. But it's also a mobility movement. It's a mobility exercise. I'm going through that mobility, and I'm also strengthening those muscles. And from this, I can go to an even better exercise for mobility called the scarecrows, which I don't think I've done a video on yet, but I will be. Over here, kettlebells bottom up press. Boom. Another great exercise for mobility. If your lats are tight, guess what? They ain't going to let the kettlebell go straight up at 180 degrees. It's going to fight you. It's going to try and pull you forward, but that's part of the exercise, is getting it as straight up as you can with control without letting the kettlebell move you. And that's great for a whole bunch of other shoulder stabilizers as well, including the rotator cuff. Over here, kettlebell halos. Fantastic. 100% mobility and strength. Everything's getting stronger while you do this, and you're also improving your range of motion. You're stretching some muscles when going one direction and shortening and strengthening going the other direction. And that's where my mind is starting to go to is, yes, mobility is awesome, but mobility with resistance is even better. One last video, or a couple of videos to look at here, and that's the ones that go after myofascial tightness. Again, this one I would not do unless you've been cleared by a medical professional to do so or instructed by a PT to do, because they're painful and because it can cause a little bit of bruising and such, and you don't want to do that unless you've been cleared by a medical professional, of course, to do so. But these are ones where I think it kind of gets into a different area. If you're having myofascial tightness, a lot of the times that's why physical therapists want to do dry needling, for example, is they want to go in there, release that trigger point. And when that happens, the muscle, which was in a knot, is now released and lengthened, and that allows for better motion. But the goal is still the same. I'm going to restore your mobility, and then I'm going to strengthen it. For dry needling, though, you typically can't do that in the same session. You're going to have to release the muscle and then strengthen it at a later date. But real quickly, encapsulate everything I've said so far. We used to think of it as mobility first, then strengthening second. I'm starting to think of as we should be doing mobility and strengthening at the same time, especially in the shoulder, because there's so much going on in the shoulder that most people don't catch, including newly graduated physical therapists. And that's what this is trying to do, is trying to educate and drive a conversation that you can have with your mentors, where it's, hey, maybe I should be trying to find a way to load them in a movement pattern like flexion or extension or whatever to help actually improve their range of motion while also strengthening other muscles and helping relieve tightness by just introducing mobility that they should have anyway. So that's been the live stream. It's part one of the shoulder. Yes, I know we went really, really deep into mobility in strengthening, because that is a component that I'm trying to learn and get through my thick skull. So hopefully you find it interesting as well. Comment, let me know what you think. Let me know if you disagree and why you disagree. This is part of the driving a conversation that we're all learning. I by no means have all the answers, and I am experimenting with a new philosophy, if you will, to approach this, where instead of just having myself do stretching, I'm going to try and stretch by loading. And I'm going to try and strengthen things by how I load them. So thank you all for watching. Please don't forget to like and subscribe. Shout out to my patrons. They're amazing. They're one of the reasons why I'm able to do this, the chief reason why I'm able to do this. But stay healthy, stay fit, keep being awesome. I hope that you all had a happy holidays, Merry Christmas, Happy Hanukkah, and all of those this Christmas season, this holiday season. Please don't forget to like and subscribe, comment, and let me know what you want to see next. And I'll catch you all in the next video.